My name is Paul Golin, and I am the executive director of the Society for Humanistic Judaism. And we have a pluralistic initiative called Jews for a Secular Democracy, in which we try to galvanize the Jewish community around issues of separation of church and state, and feel that this is something that should cross denominational and ideological lines to help Americans keep government separate from religion and vice versa. So we're thrilled today to be having this conversation. I want to introduce our guests. We have Ian Sherman is a nurse practitioner at NYU Langone, working on the front lines of the epidemic here in New York City. I'm also in New York. He received his Doctorate of Nursing Practice from Hunter College and has an interest in the intersection of culture and healthcare, especially in the ways that religious identity impact desires and expectations during healthcare delivery. He lives in Brooklyn, New York with his wife and 2 children. And Dr. Paul Offit is director of the Vaccine Education Center at the Children's Hospital of Philadelphia, as well as the Maurice R. Hilleman Professor of Vaccinology and a Professor of Pediatrics at the Perelman School of Medicine at the University of Pennsylvania. He's an author and I think the preeminent voice pushing back against the so-called anti-vaxxer movement. And perhaps most importantly, he's the co-inventor of a rotavirus vaccine that has saved countless thousands of lives. So we're honored to have both of you with us today. And just the way we thought this could work is I will interview Dr. Offit for a bit. We have a bunch of questions that we want to put to you. And then my colleague, Sarah Levin, will field questions from the folks who are participants. There is a chat box that you can put questions into. There's also a Q&A at the bottom. I'm not quite sure. I think they work a little bit differently in that we can answer Q&As as written text. But either way, if you put it in the chat or in the Q&A, Sarah will see it and we'll ask it of Dr. Offit, and then we will do the same for Dr. Sherman in the second part of the interview. So again, thank you all for being here. Thank you to all the participants who are here. So let me just start it off with Dr. Offit and ask, where's the vaccine for this? No, just kidding. I presume you don't have one yet, or we'd all already know about it. So let's kind of start off more in a macro level of since Jews for Secular Democracy, as I mentioned, our focus is kind of how our government works in relation to science versus religion and so on. What is your view on how our governments, federal, state, local levels are currently handling the coronavirus pandemic?
Well, I think poorly. I mean, if you look at countries like China or South Korea or Japan or Singapore, they've gotten on top of this much more quickly than we have in Germany, which is a population of about 80 million people. So roughly 1/4 of our size has proportionally half the deaths. So, and are now in the process of getting back to work because they have testing in place, because they've been able to effectively get that testing out there. I think we were slow to prohibit people from endemic regions from coming into the country. I think we've been awful about getting testing out there to sort of educate us about where we stand. I think that our ability to provide personal protective equipment as well as masks and others has been woeful. I think we've just trying to catch the tail of this animal since it came into this country. It's not us at our best.
What do you attribute to the difference between us and, China obviously is a very different kind of government, but Germany?
Germany's democracy. I mean, why are they, they're not any technologically more advanced than we are any more than South Korea. South Korea had done testing on 200,000 of its citizens before we'd done testing on 500. There's no reason that we couldn't have done that as well. We just were very slow to react. Why? I mean, I think, from the federal government standpoint, things were haphazard and sporadic, and or the governor's going to be doing this, or the mayor's going to be doing this? Is the federal government going to be doing this? I just think we were we have not had clear leadership at many levels, and it's hurt us.
Thank you. So one of the things that we've seen come out of this is a handful of states have included religious exemptions to their stay-at-home guidelines, and we've even seen some governors overrule local officials' orders to shelter in place. And so regarding the relationship between religion and science and government, and in light of the First Amendment freedom of religion, when is it okay for government to step in and require citizens to take specific medical actions or precautions, and when isn't it?
Well, I think that you should not be at liberty to allow yourself to catch and transmit a potentially fatal infection. I don't think that's your First Amendment right. The degree to which you hurt others is not your right. There's that, I'm sure you know this better than I do, that 1945 Supreme Court ruling, while you were at liberty to martyr yourself to religion, you're not at liberty to martyr your child to religion. So I think if staying in place or sheltering in place, locking down, affects the transmission of this virus, and it does. I mean, Sweden is probably the control group. Sweden, has a pretty laissez-faire attitude on this, and their population of 10 million people, they have about 1,300 deaths, which would amount to about 42,000 deaths here, so about a third more than we actually have. So that's what happens when you don't pretty much do anything. So clearly locking down matters. And if you say, look, it is my religious belief that I can go out there and transmit the virus, religions teach us to care about our children, care about our families, care about our communities across the board. So how is this an example of that? The minute people say in this country, this is my religious belief, everybody stands back, especially politicians. They don't want to touch that. And so therefore they allow people to do things that hurt themselves and others. And it's unconscionable. I wish they had a little more backbone.
Right. And of course, you've seen this, you've worked for many years on the issues of vaccinations, and there's been this wave of, I don't know whether it's religious or superstitious reaction to vaccination that I think has a parallel in that people are saying, well, there are religious exemptions for vaccinations, for example, by certain states. I think that there's been a movement lately to address that. So do you see the kind of similarity between the work that you've been doing on that issue and what's happening now?
Yes, very much so. I think it's very much that. There's nothing religious about allowing your child to be put in harm's way unnecessarily. That's a distinctly unreligious thing to do, uncaring thing to do. Uncaring for your family and for your community. So it's the opposite of a religion. But in this country, we don't like to tell people how to practice their faith. We don't like to tell people how to raise their families. And so invariably we stand back, and it's hard to watch. Actually, it's interesting. The first state to eliminate a religious exemption was actually Mississippi. I mean, not one you would necessarily pick first, but they're the ones who did it first. And it was the Brown v. Stone ruling, and it was great. It was basically a sort of a 14th Amendment argument, which is due process and equal protection under the law. That just because your parent, essentially what they said was, just because your parent holds an ill-conceived belief, in this case that vaccines do more harm than good, that doesn't mean that you should have less protection under the law. So we are going to protect those children under the law. It was a great ruling, I thought.
Yeah, and it's a real example of where government does step in. There are some religions or religious sects that would say, we won't use medicine, we won't use modern science. God will take care of this for us. And in those examples, government does step in, and it's one of those cases where, I personally agree that government should step in. In Judaism, I think we do have an emphasis on life. And in an interview a few years back, you describe yourself as, quote, more ethnically Jewish than religiously Jewish. So do you think Jewish values inform your perspective and your work? And if so, how have they done that?
I think growing up, my brother and sister are far more at least ritualistically religious than I am. I mean, they're much more hooked into what one does in terms of the holidays, et cetera, than I am. But and my brother and sister are closer with Orthodox. We were raised conservative. My brother and sister drifted more to Orthodox Judaism. But I pretty much just backed away. But did it affect me growing up? Of course it did. I mean, I remember reading a lot of stories in Hebrew school that had a moral base. But I was also influenced by the sort of cultural moral stories that were always out there, whether it was sort of Leave It to Beaver or Room 222, or, the movies I saw, stories where there was a series of stories for children called The Moffats, sort of about a family written by Eleanor Estes that was influential. So I think I was always drawn to those stories of morality, either because was my base in sort of Judaism, or just because it's just human.
Right, great. So speaking, beyond the personal and more toward the communal, do you think Jews have a particular voice to contribute or an angle on this in encouraging fact-based and science-based policy decision-making? And, I guess this is kind of a question for us as organizers around Jews for a Secular Democracy, but what message would you like to see getting out there more?
Well, to stick to the science. I mean, we live 30 years longer than we did 100 years ago. The reason for that are scientific advances, period. I mean, that's why we live longer. And I think we've evolved over the past 50 years or so from what I would argue was scientific literacy. I mean, just not understanding science, because it can be difficult, to scientific denialism. People just declare their own truths, right? I mean, vaccines cause autism, climate change is a hoax, creationism and evolution are equally valid hypotheses. I mean, that's rules of the day. You have an administration whose Secretary of Education is a creationist, whose vice president is a creationist. I mean, the Environmental Protection Agency had to take the phrase climate change off its website. I mean, this is well beyond scientific literacy. It's much worse than that. People just declare their own scientific truths, and it's frustrating.
Yeah. And, I presume you've experienced it. It seems, there's kind of a stereotype about the Jewish doctor and that Jews go into medical professions, science, and I think there's a lot for us to be proud of as a community in terms of promoting science literacy, recognizing that, regardless of belief, this is the world we live in, and let's try to understand it as best we can and improve human life in the here and now, regardless of what you think might happen in the hereafter. Do you think that there's something there, even for secular Jews, that relate somehow to their Jewishness, or do you just kind of think maybe I'm being ethnocentric about that?
No, I think you're right. I mean, my world's the world of vaccines, but I mean, look at all the Jewish people who were vaccine inventors. So, you have Albert Sabin and Jonas Salk, Stanley Plotkin, Peter Hotez. I mean, there's a lot of Jewish people in this, and I don't know, I'm not sure why us. I mean, and maybe it's because we sort of were always kind of on the outside looking in, and so we were very good about studying the way things worked, whatever it was. But do I think we have a responsibility? I think we all have a responsibility. I'm not sure there's anything unique about being Jewish that means we have a responsibility, but we do excel in science and math, et cetera. So yeah, of course we should get out there. And it's interesting that really the first scientist to get on TV and try and explain what was going on was Jonas Salk. Really, I mean, he was sort of the March of Dimes poster boy, and he was out there, and he was ridiculed for it. It was hard for him, actually. I think he was never elected to the National Academy of Sciences. I mean, I've been elected to the National Academy of Science. Not that hard. And he was never elected. This guy who basically solved the polio problem, and in part because he got out there, and people didn't like it that he was out there, that he was the voice of this. So,
what were their objections?
That they thought he was cheapening science by trying to explain it to the public.
Wow.
But, yeah.
Wow. Interesting. I hadn't known that about him. So we're hoping for a coronavirus vaccine. I'd be curious to know what you think the timeline on that might be, or what the rollout might look like. But when that happens, not if, when it happens, what are you going to say to people who may be fearful around a new vaccine? Would you be first in line to take it? You know, how is that going to work?
Right. So I'll start with the good news. The good news is I think we can make a coronavirus vaccine. I mean, you know, there are early studies years ago looking at human coronaviruses, which are not they're more of a cousin to this particular novel coronavirus than actually a brother or sister. But if in experimental human challenge studies, you could be infected with one particular type of human coronavirus, and that would protect you for a year or years. So that's good. That means you can make a vaccine. We also know the protein we're interested in. We're interested in that if you look at all the pictures, whenever the media shows a picture of the virus, there's always those little spike proteins on the surface. Well, that's the attachment protein. That's the protein that allows the virus to attach to cells, therefore enter cells. So if you can prevent the virus from attaching to cells, you're going to prevent infection. So we know that. That's good. And we live in an era of recombinant DNA technology, so we have a lot of things we can do quickly. The problem is we don't know how we're going to make this vaccine. I mean, either it's going to be a whole-killed virus like polio vaccine, or it's going to be a live weakened virus like measles, or it's going to be a purified protein like hepatitis B or human papillomavirus, or a completely novel strategy, the so-called genetic strategies like messenger RNA or DNA, for which we have no vaccines. I mean, there is not a messenger RNA or DNA vaccine out there. So I'm on the FDA's Vaccine Advisory Committee. I mean, in theory, any new vaccine has to come through our committee before it gets licensed. I cannot imagine how you can, not even knowing what the strategy is right now that you're going to do, or the dose for that matter that is going to be required. And you don't really know what immune response you're looking for yet. You don't know what is a protective immune response. Those are just basic things. It seems like we've skipped past animal model work and are now just going right to human trials. You would have to do hundreds and preferably thousands of people in phase 1 and 2 studies to prove you're just proof of concept that this looks like it might work. Then you would have to do, you know, large phase 3 trials, meaning prospective, placebo-controlled trial where half the group gets vaccine and half doesn't. I mean, for our vaccine, the coronavirus vaccine, that was a 70,000 person, 4-year, 11 country, $350 million trial. And that was one trial that took 4 years to do. So assuming that, and you don't know the attack rate by the time you finally have the vaccine, assuming the attack rate is high, so therefore you can get a number of people who were infected or not infected on both sides, I can't imagine that takes less than a year. Then you have to do the hard part, which is scaling it up, meaning, you know, making it for tens or hundreds of millions of people, which means you have to have the right buffering agent, the right stabilizing agent. You have to have the right vial. You have to do real-time stability studies. I mean, I'm serious. If I think everything worked great, I think this would take 5 years. So when they're talking about 12 to 18 months, I'm obviously missing something. And I think the things I'm missing are they're not going to go through the FDA. This is going to be through this emergency use authorization, and they're just going to say, we think this is going to work, and the FDA can stand back. It worries me. I mean, the BARDA, which is this subdivision of Health and Human Services, stands for Biomedical Advanced Research and Development Authority. So they just gave $483 million to this mRNA vaccine. So mRNA just stands for messenger RNA. When you're injected with this messenger RNA, that's translated to a protein, that protein that sits on the surface of the virus, to which you make an immune response, which should then protect you. We don't have a messenger RNA vaccine. I mean, in order to deliver that, it has to be surrounded by a complex lipid delivery system, which has never been scaled up and which may have side effects on its own. You don't know any of these things, and you're about to give a vaccine to, as Francis Collins said on a conference call the other day, as many as 1 billion people. You better make sure that this is as safe as you can make it before you put it out there. And I just worry about this. I worry that corners would be cut, and that would be tragic if that were true. I mean, we need a vaccine. The only way you're going to get population immunity, herd immunity, community immunity is with a vaccine. You're never going to get enough natural infection to prevent spread. You're not. We could do it with measles. We can't do it with anything. You're going to need a vaccine. True. And we're desperate. We're terrified. We're panicked. So we're willing to cut corners. I just am worried that, and go back to the Salk vaccine. It's a perfect example, actually. So when Jonas Salk made his vaccine and it was about to get licensed, there were 5 companies that stepped forward to make it. The length of time it took for that vaccine to get licensed was 2.5 hours, okay? A lot faster than it is today, which is on average about 10 months. One company, they all had trouble scaling up the vaccine. They all had trouble inactivating the virus. That's what Salk did. Took polio, killed it with formaldehyde, and that was it, whole kill virus. One company made it badly. Cutter Laboratories of Berkeley, California, didn't fully inactivate that vaccine. As a consequence, 120,000 children were inoculated with live, fully virulent polio virus. 40,000 developed short-lived polio. 200 were permanently paralyzed, and 10 were killed. I think it was one of the worst biological disasters in our country's history, and that's what happens when you go too fast. So make sure you get it right, is all I'm saying. Because, I think our feelings about vaccines are fragile. And I think we lose a lot of credibility if we get out there too quickly.
Thank you. That's really helpful.
Depressing, right? Depressing. Did I depress you?
Depressing. It's depressing, but and now I'm putting my humanistic Judaism hat on, which is, we'd rather have the truth and then deal with it and deal with whatever that might conjure up in us. And really, ultimately, then it's about how we react to it when we have all the information in front of us. So to me, it is helpful to have that information. It's very sad and scary to hear your perspective on it. But I agree that if this is rushed, think of the incredible damage it does for these folks who are pushing back against proven safe vaccines. You've got vaccines out there. I mean, I have young children and they get vaccinated, and I feel confident in their doctors and in the system, right? And then to do something with that system, and I understand the motivation would be to save lives. So it's a very challenging situation. So just one follow-up question to that then is, how about the ramping up of testing? Like, what's holding up that? And so my wife, who's a flight attendant, actually, we now suspect she may have had this at the end of February, even before the first cases were reported in New York City. She had all the symptoms, but we don't know because we can't test her to see whether she had it or not. Is that coming? Would that be something we could expect in months rather than years?
We should have it now. There's no reason that South Korea should have tested 200,000 people before we tested 500. There's nothing about South Korea's scientist or economic structure that should make it any different than ours in terms of being able to get testing out there. I think it is our single biggest failure. I mean, look at Germany. Germany is going back to work. They're going back to work because they're doing the kind of testing to tell you who's shedding virus and who's not. They're doing the kind of serological testing to say who's likely to be protected against this virus and who's not. We don't have any of that really in place. It's completely haphazard and sporadic, and there's no excuse for that. I mean, it's hard to watch, actually, the way we have handled this as compared to other countries which have handled it far better than us.
Yeah. Well, to me, that's kind of the hope that I'm pinning on now, because at least if we can get testing and we can, as opposed to what seems to be floating out there, which is let's just reopen the country and see what happens, which is horrifying to me. At least if we could know who has it and who doesn't and take precautions that way. Well, I really appreciate all of this information. I find it very helpful. And Sarah, have there been questions that have come in?
Yes, lots of questions for you, Dr. Offit. So I'm going to get started so we can get to them all. From David, he said, the anti-vaxxers are already claiming that generating an immune response to the spike protein might create antibodies that cross-react with whatever else normally attaches to the angiotensin receptors. Hope I pronounced that right. How do you counter such autoimmune fears?
Actually, I don't think that per se is going to be the problem. The sort of cross-reactive antibodies with the binding, the spike protein on the virus binds to a receptor on cells called angiotensin converting enzyme. I don't think cross-reactivity is a problem, but they do, oddly enough, hit on something that might be a problem, which is that when you make antibodies to that protein, that spike protein, you want it to neutralize the virus. So there's sort of the spike protein has the business end of the spike protein. So it's just like, this is a spike protein. I spent a lot of money on this particular graphic, but if this is the spike protein and this is the business end, the cell attachment end, that's where you want the antibodies. You want it directed against that business end. You don't want it sort of to bind to the protein, but not neutralize the virus. So-called binding non-neutralizing antibodies. Because then what can happen is those antibodies can sort of attach to cell receptors called FC receptors, bring it into the cell, and actually enhance the ability of the virus to cause harm. It's called antibody-dependent enhancement. It's what we saw with the dengue vaccine. So in other words, you were actually better off not getting the dengue vaccine if you'd never seen dengue before than getting it. And children died because of that. So Do I think antibody-dependent enhancement is a theoretical problem? I do. But I do think that's an answerable problem by doing a large-scale prospective efficacy study to make sure that's not a problem. You know, you can rule out uncommon events pre-licensure. It's very hard to rule out rare events pre-licensure. I mean, Maurice Hilleman, who I consider to be the father of modern vaccines, said it best, quote, "I never breathe a sigh of relief until the first 3 million doses are out there." That's always true. But you can at least hedge your bets by doing as big of trials as you can. I mean, we did for rotavirus a 70,000 child trial. The other rotavirus vaccine, 60,000. Pneumococcal vaccine, 35,000. Human papillomavirus vaccine, 30,000. Get into that range. Get into the tens of thousands, and at least you can feel better about this. But I mean, so there are some theoretical concerns about this vaccine. Yes.
Thank you. Next question from Richard. Have you seen politics affecting the FDA at your level of involvement? No.
I mean, for the FDA advisory committee, it's always about data. No, I don't see that at all.
That's very good news. From Dell Outwood, how is that sort of a trial, and I think he was referring to what you were describing before, how is that sort of a trial able to be done quickly without intentionally infecting people? So I think there's a little bit of, if you could just explain how those things work.
Yeah, so what you do is you think you have a vaccine. Now you have thousands of people. You divide them in half. And I think the group that would be tested first would be healthcare workers. Like Ian, I mean, people who are on the front line, who are most likely to see this virus and see, you know, a larger burden of virus because they're getting closer to the patient. So you vaccinate half and you don't vaccinate the other half. And then what will happen is you just let them naturally be challenged and naturally encounter the virus. Presumably half will encounter the virus that got the vaccine. The other half will encounter the same amount of virus that didn't get the vaccine. And then you'll see whether or not your vaccine protected against disease. That's the way that works. But, you know, it really depends on how common that virus is in terms of spreading in the community at the time that you do those trials, which I imagine would be, you know, at least a year from now. Will this virus still be as potent then as it is now? Because obviously the less that virus spreads, the bigger the trial needs to be to capture a critical number of people who are infected or not.
Thank you. Here's another question from Debbie. She said, what are the limiting factors of this particular virus for creating herd immunity through natural means? Is it the low incidence rate?
Yeah, I think there's only one way to truly get population immunity, and that's with a vaccine. I don't think you can ever really get enough population immunity with natural infection. I mean, I'll use measles as an example. I mean, I'm a child of the 50s, I had measles. Therefore, I am protected against measles for the rest of my life. Unlike this virus, which would probably induce protection for a few years, but not for decades. I'm protected against measles for the rest of my life, as everyone was when measles circulated in the community. Nonetheless, every year there'd be 2 to 3 million cases of measles, 48,000 hospitalizations, 500 deaths every year in this country. The only way we eliminated measles was with a measles vaccine. And with that, we finally eliminated measles in the year 2000. I think that would be the only way to do this. Although it does worry me when Tony Fauci says, Dr. Fauci says, you know, that we can't have large-scale sporting events until we have a vaccine. Hey, I'm a Philadelphia Eagles season ticket holder. I got to wait 5 years till there's a vaccine. This is getting very personal for me.
I have a whole trip scheduled to go up and see Derek Jeter get into the Hall of Fame in the end of July. Is that definitely off, or can I hold out hope for that?
I think that until we have to calm down about this. I think here's what I would say. We did what we said we were going to do. The goal was to try and flatten the curve, make sure the healthcare system wasn't overwhelmed. I think we've largely done that. And certainly the doubling time for deaths and cases has dramatically increased, meaning from 1 day to 2 days to 4 days to 5 days. Now we're at 8 days doubling. So that's good, I think. So now people are scared. Now the rules have changed a little bit. You know, if you go back too quickly, then you're going to overwhelm the healthcare system again. So go back slowly. I mean, just test the water with 1 foot. You know, find out who's susceptible and who isn't. Find out where who's infected and who isn't. Older people who should stay home. I mean, people who are sick should stay home. People who come in contact with people who are sick should stay home. But start to get into the workplace, because we are moving into round 2 of a major public health disaster. I mean, round 1 was the virus, right? Suffering, hospitalization, death. Round 2 is massive joblessness, which could be as many as 35 million people who are out of work, which will mean many people who are homeless, and all the things that come with homelessness, food insecurity, domestic violence, child abuse, suicide. I mean, that's round two. So let's try and start to get back to work. I mean, other countries are doing that. I think there's no reason we can't do that. But again, we lack sort of any concrete leadership to tell us how to do it. First you have, it's going to be April 12th. We're all going to be back in church, celebrating Easter. Then it's April 30th. Then it's May 1st. Now we're going to make you go back. I mean, what are the rules exactly? Just have some smart rules for how to slowly get back into the workplace.
So we have two more questions from Jeff Justice, and then I'm going to take the liberty of following up on with my own question. About a week ago, the antibody test from Heinsberg, Germany came out. Do you think the results apply to us? Are results from antibody tests in the US available? That's sort of one question. And he also asked, should the schools have been closed?
Actually, in terms of the second part, the CDC actually never recommended school closure. They didn't think that would affect the epidemiology of this virus. And similarly, Singapore was able to get on top of their outbreak without ever closing schools. So I don't think that ever had happened. In terms of the antibody testing in Germany, what they found out was far more people had been infected than they thought, because there's a lot of asymptomatic infection that would cause someone to then seroconvert, meaning to develop antibodies against this virus. Do I think that's true here? Absolutely. I think probably millions of people have been infected. We just don't know that yet. And should we ever get serological testing out there? I mean, I was on Inside Edition the other day where I was asked this question. Do you think it's valid to get a home antibody test from China off Craigslist? Which I would argue was a question that answered itself. But it's like, this is what we've come to.
So one last question I wanted to ask you was about the guidelines that the administration just put out recently, I think in yesterday or today, basically saying it's up to the governors, but listing some rules. There's some criticism that it wasn't complete enough. So I just wanted to get your reaction to their guidelines.
I'm glad that they've come out with something finally. I do think that it is true that it's probably best handled at the local level. I mean, a rural community in Pennsylvania is not going to be handled the same way as Philadelphia. So I think handling those things locally does make sense. And maybe even apart from the mayors, the governors, the mayors, right? I mean, who wins the wars? It's the sergeants that win the wars. So, I mean, I think that in some ways that makes sense to do it more locally. But I think, again, this government the federal government sort of vacillates back and forth between, I'm about to make the most important decision of my career, my presidential career, to, do whatever you want. So I don't know. I mean, it's so inconsistent, it's hard to get a hold of.
Well, thank you. That's all the questions we have for now.
Yeah, thank you so much. I don't know whether you can stick around or not, but if you can't, we really appreciate.
I can. I have something at 2, so I can stick around till at least 5:02 anyway.
Great. So I'm going to turn it over to my colleague Lincoln now.
Fantastic. Hi, y'all. I'm Lincoln. I'm the community organizer for JFASD, and I'll be interviewing Ian Sherman. Ian, thank you so much for being here. Hope you're staying safe. First question I have for you is I was hoping you could tell us a little bit about what you're observing on the front line in New York City. What do your days look like? Can you kind of paint a picture for us of what the peak looked like and where we are now, if there has been improvement?
Sure. So first of all, thank you for having me. I appreciate the opportunity to sort of let people know what's going on out there. I should say my normal job prior to this period of time, I was working in outpatient gastroenterology. But to put it sort of bluntly, nobody really cares much about their acid reflux and whether they should get their screening colonoscopy when people are dying from COVID. So thankfully, people had stopped coming, and we told them, it's not worth risking your life to get, Pepsid. So I was basically mobilized to the hospital, where I was, obviously able to be a lot more helpful. So I've been working in Brooklyn. And I have to give credit to my employer, and I wouldn't give it if it wasn't true. Is that they prepared well. They had their proverbial feces together. They had enough. I've never had to. We are using PPE more judiciously than you would at other times, but I've never seen anybody have to go into a room without proper attire. I actually even was able to get what's called a PAPR, a positive air pressure respirator, which is because I have a beard, I can't. The N95 masks or all of the masks are ineffective. So the forced air, it's hard to describe, but it's basically a forced air helmet contraption that works even more effectively than a mask, and works with a beard, so I can do, I can go into these rooms safely. And to be honest, a lot of my friends in other institutions have not been able to get a mask like that, so I've been quite lucky. I would say that the peak, the thing that I think has been so jarring for so many healthcare workers is that we are used to, first of all, having something to do. We are, those of us who didn't live through the previous medical eras where there was disease that there was nothing really to do about, like the early days of HIV, for example. We're not used to having lots of people coming in very sick and there's nothing we can do, and we're not even sure that the things we are doing are the right things, and they could be making it worse. So that has been very jarring for us. And even I think the little things that people don't think about is that I was working with people that I don't know very well, or even at all. Sometimes I was meeting these people for the very first time in the middle of a code on a patient, and we can't see each other except our eyes. So all of the communication between these people who are sort of going through these incredibly stressful, strange situations are with eyes, and you don't really know how much of communication is nonverbal and in the face, the mouth, the cheeks. That when you lose that part of the facial expression, you completely lose a lot of the ability to communicate, and that has been very, very strange. That's kind of like the more intimate, on the ground experience that I think people could think about. And then, but the flip side of that is I cannot even imagine. I've yet to have the experience of being the patient who doesn't have a nurse smiling down on them, or like giving them a loving, reassuring look. They're seeing literally that. I mean, that's got to be really, really terrible for the patients. So we try as much as we can to speak, to express our feelings in words instead of with facial expressions, but that's kind of been my sort of like really on the ground takeaway is sort of that lost personal connection that the situation has created.
Right, yeah, absolutely. On a more hopefully optimistic note, have you seen any signs of improvement in New York City? Have the cases begun to lighten up?
Yes, the RER does not look as disastrous as it did a few weeks ago, even last week and the week before. So that's definitely good. The deaths have continued to go up. I think yesterday was a particularly bad day. Tuesday in the hospital was like code after code after code, because the patients who are passing away now often have been sick for a month or more, and so there's a lag time between when the infections occurred and when the bad outcomes are occurring. So we are still seeing a lot of very, very, very sick patients, but we're so far, thank God, not seeing as many coming into the emergency room, and I'm hoping it will stay like that. Honestly, my fear has been that this virus was delayed in its entry to nursing homes and facilities that care for elderly and immunocompromised people. It was delayed, but it's happening. And when those facilities start to really get some the virus spreading within the facility, I'm afraid we're going to spike again. I hope that by saying it out loud it doesn't occur, and I'm proven wrong. I would be really happy to be wrong about that. But I saw just last night in New Jersey, there's a nursing home that the police got an anonymous tip, and they found 17 bodies in a shed that they just had nowhere else to store them. I mean, horrible stuff like that. So I'm hoping that doesn't, it is not as bad as I'm afraid it's going to be. But I think you can imagine why that would be. The fear is very real. That once that one visitor, that one staff member who's asymptomatic, who couldn't get a test, who came to work because they didn't know they were, shedding virus, and they infect the 6 elderly people who they help to feed dinner, and then those 6 infect everybody else, and then you have a whole nursing home of COVID patients. That is not good. So we'll see. But again, I'm hoping that is doom and gloom and unnecessary. We'll see.
Right. Yeah, certainly a frightening prospect. Could you share a little bit on your perspective of how the government response has been, and in particular in the New York City area, we saw this national news of the USNS Comfort docking on the Hudson River, and this field hospital constructed in Central Park and at the Javits Center. And yet we also saw these stories that they were being vastly underutilized. They sat practically empty. I'm curious what your perspective from the front lines has been on resource allocation and management of those emergency measures in New York.
Right. So at least I have not heard any direct communication or very, very limited direct communication on the type of patients that I should be sending to these facilities. And there have been patients sent, but they are not anywhere near full as far as I'm aware. And it's not clear. At first it was explicitly for non-COVID patients. And then it seems like now they are accepting COVID patients as long as they're not very ill. But not very ill is sort of weakly defined. I saw a friend of mine on Facebook, who is an EMS worker, posted a picture of the triage area at the Jacob Javits Center, which had a list, which I was able to zoom in on and read. And that was kind of the most information I got, not anything more than that. But it's not really clear to me who I should be sending where. The very sick COVID patients certainly are coming to the hospital. That's where they should be. So we kind of have been identifying hospitalized patients who normally would probably be staying in the hospital to recuperate for, let's say, another 2-3 days, but that's a precious bed and their life is not in danger. I mean, I cannot even tell you how many conversations I had on the phone with, like, hello, Mr. Smith, your dad is doing much better, thank God, doing really good, and you rattle off all the ways he's doing well. Normally, we'd like to keep him here for another 2-3 days to make sure that his progress is maintained. Right now, this hospital bed is precious, so we're looking for different places where we can sort of help him bridge the transition so he can transition home safely. So those conversations have been often led to, like, this is the person who might be identified to go to the Javits Center. But then, honestly, I'm not even honestly clear about whether they make it. We're kind of just, by the time that patient is discharged, it's not clear. To me at least, it's not clear where they ever end up. I don't get report back. And we've had, one of the things that bothered me the most, we had a gentleman who, I didn't ask, but what I gathered was that he had no legal status in the US, and he didn't have health insurance. And he was probably not contagious, but it wasn't entirely clear if he was still contagious, but he was clinically improving, thank God. So we were basically telling him that we're going to discharge him home. We have to discharge him home. We need this bed. He didn't seem to qualify to go to the Javits Center. And we were discharging him to a single room that he shared with his entire extended family. How are you supposed to socially distance in one room? I mean, kids, there didn't seem to be any elderly people as far as I could get out of him. He wasn't so happy to share many details, which I certainly don't blame him. So, it's been stuff like that. And I wish, again, this is something to learn for God, for the next pandemic, that there should be clear recommendations ahead of time. So we'll know without anybody even having to tell us that one of these surge capacity facilities like Javits Center and the USNS Comfort are available, who can go, how you get them there, how that handoff goes. That to me at least, and I could be that there are other people who could be that like I said, the hospital had a lot of this well prepared. It could be the reason I'm not hearing about it is because there's somebody else doing that job. Honestly, it could be. So, but at least for my level, I didn't get any good information.
Yeah, it definitely sounds like y'all are responding to the challenges as they come up one at a time, which, from a planning perspective, something we need to look at going forward. Right. Shifting gears a little bit, can you tell us about the Jewish community that you belong to and how that community is responding to this pandemic? Has it been particularly hard hit, and what their measures to react have been? Right.
So my community, I live in Crown Heights, which is sort of central Brooklyn. We have been extraordinarily hard hit. And actually, as we speak, there was a funeral for one of my neighbors passing. We've had, like, I've lost, so many fatalities of so many people, like ridiculous numbers. And that has been true in a lot of New York City's Jewish communities. I was part of, about a year and a half ago, starting when the measles outbreak hit the Jewish community. I had the privilege of being part of a healthcare sort of group of people getting together to sort of like try to shake people up and be like, this is insane. We need to respond. We need to get people vaccinated. We need to close, programs that are refusing to, to protect children. I thankfully was part of an organization that of religious Jewish people in New York City, responding to the communities and trying to educate people and sort of mobilize change. And I feel like that sort of that dry run, in a manner of speaking, helped, because this time around the leadership of these communities responded much faster. The schools in my community, by and large, closed even before public schools closed. Even when there was not yet a recommendation to close schools, we had closed the schools. The synagogues, were closed. They canceled religious, events way ahead of time, even earlier than other organizations were closing. So that is good. But these Jewish communities spread infectious diseases really well. I mean, the average American has Thanksgiving dinner once a year. We have the equivalent of Thanksgiving dinner at minimum twice a week. This past week, it's going to have been 6 times in a week. The week before that, it would have been 8 times in a week. We have massive multi-family, multi-generational meals with neighbors and friends and everybody multiple times in a week. We gather in synagogues far more frequently than Christian communities gather, and often in much more confined spaces. Diseases spread really quickly in Orthodox Jewish communities, really, really, really quickly, which is why you saw the measles outbreak, was particularly, our communities were particularly hard hit, and why this has been so intense in the Orthodox communities. So Crown Heights was, I believe I actually had COVID. My wife and I had it before Purim, which is now more than a month ago. I actually, the day that commercial testing became available in New York State, I was able to use my luck and agency as a healthcare worker to get a test, I tested negative. But I am relatively positive I had it, because I had the symptom pattern. I was able to get some blood testing, which my blood cells changed in a way that is pretty consistent with an infection with COVID. I'm pretty sure I had it. But most people in our community couldn't get the test that I got. And so therefore, the day after I had the test, where I was sitting in quarantine waiting for the results, I literally watched out my window as thousands and thousands and thousands of people exchanged gifts for Purim, and I literally sat there watching and being like, this is a joyful day. It's supposed to be, but I'm watching this pandemic explode in front of my eyes, like right in front of my eyes, and that came to pass. Those people, many of them have passed on now. Like literally people who I watched on the street. So that sort of sums up my community.
Yeah. Well, disheartening to hear and very sad, certainly. On a more personal level, could you share how your Jewish values have sort of informed your own perspective throughout this crisis, and really why you got into healthcare?
Sure. So this is the very big can of worms, but to try to focus on the most relevant part here. Judaism, for me, as a healthcare worker, it sort of gives some structure to the thinking around the value of life and why we work so hard to save life, and what does it mean to save a life. In other words, if I put a person on a ventilator and they never have another waking, conscious, so to speak, normal thought for the rest of their life, and I saved their life, or am I just prolonging their death? That's a humongous discussion of medical ethics, and there's a lot to be said about that. But I really do resonate very much with the idea that life is about more than just pleasure and contribution and even rational thought or things like that. I feel there is a value in life that is not productive in the ways that some people might define productivity. A lot of healthcare workers disagree with me, and that's a debate that I've had. It's something that is very it's a lively discussion in the healthcare world about when we're putting a person on a ventilator. We're talking pre-COVID, in the before times when going on a ventilator was relatively rare and for other usually often untreatable problems. So my Jewish values, the Jewish sort of like context of that there's value in having a soul in a physical body in the world, and what that means and why that's meaningful, makes it a little bit easier to care for these patients who otherwise just look like, a body with nothing in it, just organs and organ systems functioning with no mind. And for a lot of workers, that's extremely hard to do day in and day out, because if you feel that this is basically a sack of bones and meat, not to be really, I'm not trying to be, what's the word? I'm trying to, in other words, it's really hard to sit there and see this person. If you feel that they're sort of just like hanging out between life and death, and they might as well just die already, to be really blunt and crude, that's the approach that some people sort of come to after sort of the years of being sort of emotionally, affected by the work they're doing. Having the idea that there's some value to this, that this God did not allow this neshama, this soul, to stay in the world for no reason, for no purpose. That it's here for a reason, makes it much easier to work with these patients. I have found,
Right,
and that's definitely applied here. We have these COVID patients who are, dying and are very, very often unconscious for days or weeks before they die. Caring for them would be hard anyway, and to know that to feel that there's a value to their continuing existence for those days and weeks is meaningful to me.
Very interesting. Well, the last question I have for you is one that's forward-looking. What should be the role of the Jewish community, and what should be our response, taking what we've learned from this pandemic to hopefully avoid some of the community spread that we've seen going forward? In other words, what should the Jewish voice be in this? What is our responsibility to protect our community, learning the lessons that we've witnessed in the past weeks and months?
So you're saying the immediate role, like in the coming weeks and months.
Yeah.
So sure. I think, like I said, the Jewish community is very communal. We do big meals, we do group celebrations, we do even in death. We have sitting shiva, and people come and see each other, squeeze each other's shoulder. So as much as there is humongous temptation to get back to that as soon as possible, and for good reason. There are thousands and thousands of families. My neighbors next door, I should be in their house right now comforting them because they lost their father and grandfather, and I'm not going to be, and I shouldn't be anytime soon for the families who have their loved ones are going to die in the days and weeks ahead. Because as much as it is tempting to restart all of that traditional community work, hold off from doing that, and can explain to the world why we're holding off, then I hope that we can be sort of leaders that people won't go back to church, and then people won't go back to sporting events. Like if the Hasidic community is not sitting shiva, you shouldn't be at an Eagles game. With all, I'm sorry for his loss of games, but if my neighbors can't sit shiva properly, then I think we're going to have to hold off on baseball and football and everything else. So I think that's a way that we can sort of show the world that this is really meaningful, huh? It's easy for me to say. I know, but I think we would. That is something we can say. This is something we can show the world what we would normally be doing. We are not doing that, should not be doing that, and are not going to be doing that, because that's how important this is. And this is very, very, very deeply valuable things to our community, and we are holding off, and you should hold off too. I hope that is the message that our communities are able to send.
Absolutely. Well, thank you so much. I'm going to toss it back to Sarah to see what more questions we have.
Yes, we have a lot more questions and just a few minutes left, so I'll get to as many as I can. I think this is directed at you, Ian. How many people have been waiting too long to go to the hospital? How has the instruction, if you have symptoms, stay at home, worked out?
So this is a double-edged sword, because we need a lot of what I have been doing the last few weeks is literally sitting in the ER with people who have come in, walking them, and if they can maintain oxygens above 92-ish without oxygen through their nose, they should be going home. Unless there's another reason to keep them, we're sending them home from the emergency room, which is insane, because at any other time, a person who's walking around with a 92 oxygen would be admitted already. So people know that, and they are not coming to the hospital, which is part of why the curve was flattened. The ERs were not overrun with people where we would have had to weed out the critically ill patients from the people who were not yet critically ill. So that was good. However, there is no question that there are people who have died at home because they did not come in time. So the balance of looking back, should we have been encouraging more people to come sooner? And therefore some of those lives may have been saved. But that would have also meant if we're encouraging them to come, we would have gotten, for every one truly critical patient whose life we could have saved, we probably would have gotten tens or hundreds who were truly ill and at any other time would have been admitted to the hospital. But in this case, we would have been sending home because they're not quite sick enough to admit in this current period of time. So it's hard. I think it's hard to know that we probably the people who encouraged patients to not come to the hospital probably contributed to people staying home and dying at home or coming too late. But we also, I'm sure, saved many lives by keeping the worried well or the worried not so incredibly sick at home. So that's tricky. It's tricky.
Yeah. Another question from PJM. When Jewish patients pass, are they being seen by rabbis or Kadisha Society? How are arrangements being handled?
Right. So there's an organization called Chesed Shel MS.
Thank you, Dr. Offit.
Well, thank you, guys.
Thank you, Dr. Offit. I am a fan.
Thank you, Aaron. Yeah, nice to say that. Appreciate it. Good luck with you guys.
Thanks. So there are where families have often not been able to, almost never been able to be present, which is very, very hard. There's been, as often as possible, people calling family members and like maybe putting them on speakerphone to say, to pray with them at the end of their life. The rabbis, by and large, have not been in the clinical areas because that would be a set of PPE that somebody else, is deprived of when the rabbi has it. So I have yet, honestly, where I have physically been working, there are very, very few Jewish patients. But my understanding is that even in the units where the Orthodox patients are being treated, I don't think there have been any rabbis at the bedside. I have yet to hear of one. But after the patients pass away, there are several organizations. Chesed Shel MS is one of them that does incredible work. That they sort of taking care of any Jewish patient, but especially the patients who maybe don't have anybody to help with arrangements and burial and the preparation for burial. So there's a lot of that work is being done. The funeral parlors are literally overrun. There's a video I saw last night of literal like backlog of bodies lying. Properly prepared in a coffin, but like bodies waiting to be prepared in a funeral home, which would never ever happen in normal times in a Jewish setting. People are usually like rushed through and being buried as quickly as possible, and that's been impossible now. So I think that I'm now forgetting what the question actually was, but I think that was the answer.
Yes, it was. Thank you. Do we have time for another question, or would you like to wrap up?
I have a minute. Yeah.
Okay, so David asked about your personal experience becoming a nurse in a community that can at times be skeptical of science. I know you touched on this earlier, and luckily the work you did before with measles helped with this round. But if you could maybe just speak to that and any pushback you've ever received, or maybe this is a misconception.
Right. So there's a few answers. First of all, I'm a little bit of a different case because I did not grow up in this community. This is another webinar. But I sort of became an Orthodox Jew in the middle of my nursing training. So there definitely was pushback, like if after coming to this community, like what are you doing in college? And I don't understand, like what are you doing? There's some of that. But by and large, I think it's not quite fair to say that the communities are anti-science. I think there is some skepticism of science in some areas, but it's not. I don't think it's the skepticism occurs in the way that people think it occur. I mean, I don't want to say that there's none, because there is some. And there's definitely some ignorance of how science works or scientific principles, which was a big problem in the vaccine fight. That's not unique to the Orthodox community, but there definitely is some in the Orthodox community that has a sort of an Orthodox flavor to it. But I think by and large, if people see that you're living your Jewish values fully and you're not apologizing for them, then that's their sort of take is, oh, well, if he's doing that or she is doing that in a way that doesn't seem to compromise how they're living, then there must be no problem with it, and they pretty much let it be. Very rarely have I ever had people sort of skeptical of me because I have a science background or training, thankfully.
Well, thank you so much. It's really important for us to hear this perspective on all levels. You know, as a frontline responder to this pandemic, we can't thank you enough for that. And I hope you stay safe. And it may be a weird thing to say, I hope you are correct that you actually did have the virus for whatever that's worth. If it buys you some immunity from not getting sick. But I really appreciate what you're doing and also your perspective, and I'm sure we'll be in touch again.
Yeah, I cut out there for a second. Yeah,
and
thank you.
Sure, and to everybody else watching, thank you for joining us. You can find our website at jfasd.org, or if that's too many letters to remember, you could also type in jewsdemocracy.org. We'll take you to the same place. Sign up for our emails there so you can stay posted on these kind of events, and we hope to be doing more. We definitely will be doing one at 11 a.m. on Friday, May 1st, with a New York State representative, Representative Epstein, and we'll talk to him about the relationship of government and science and a pandemic and whatever else might come up between now and 2 weeks from now, which who can predict what that might be. But we're doing lots of other things as well, and we'd love your involvement, and we'd love for you to join us over there as well. So thank you again, Ian, and my co-panelists, Lincoln and Sarah, and for and stay safe and stay at home.
Thank you. I appreciate it.
Thank you.
Take care.
Bye.